Hello, 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 ladies and gentlemen, hello. Today, this afternoon, we are talking about connective tissue disorders. Class outcomes for connective tissue disorders will be to summarize the pathophysiology of the more common connective tissue disorders, identify the diagnostic studies that are associated with connective tissue disorders, differentiate between the abnormal assessments commonly seen in clients with connective tissue disorders and then the normal, quote unquote, normal adult assessment. So, we will also judge the appropriateness and safety of administering the more common medications that are used for the treatment of connective tissue disorders. We will evaluate the needs of clients with connective tissue disorders and or their families for education needed to prevent and then manage the disorder. And because we are nurses, we are going to formulate a plan of care for a client with a connective tissue disorder. So, connective tissue is the most widely distributed and abundant tissue in the body. It will provide support, structure, insulation, and cushion to tissues and organs of the body, as well as fill space. So, in connective tissue disease, collagen and elastin are damaged through an inflammatory process or an immune system dysfunction. So, bone, cartilage, tendons, ligaments, lymphatic tissue, and blood, even, are all examples of connective tissue. So, we are going to start with osteoarthritis. So, the epidemiology, the beginning of osteoarthritis, it is the most common form of arthritis. It is the leading cause of chronic disability. It will involve weight bearing joints such as the knees, the hips, the feet, and the lumbar spine. It will also affect the cervical spine, proximal interphalangeal joints, and then distal interphalangeal joints of the hands. So, some risk factors of osteoarthritis, ladies and gentlemen, listen up for the first time. You are going to want to remember this slide. Some risk factors are age, if that patient or the client is older than 55, if they are female, if they are obese, if they are overweight, and then occupations that involve repetitive motions. So maybe someone who is a machine operator, someone who is doing the same routine with their hands over and over and over again. Sometimes that can even be somebody who is sedentary and they're constantly using their hands on a computer. Then there are people that have hobbies, which they are constantly using their hands, such as knitting, crocheting. Sports, a previous injury will be a risk factor, muscle weakness, genetics, history of inflammatory arthritis, and then bone and joint disorders. Ladies and gentlemen, these are all risk factors, and please pay attention to this slide. So, obesity is the single most modifiable risk factor. You will want to pay attention to that. Obesity will correlate most closely with the development of knee osteoarthritis. There have been links made between certain occupations and then osteoarthritis. And then it is any occupation where there is going to be that repetitive motion. Aging now is the most prevalent risk factor. However, osteoarthritis is not a normal part of the aging process. It will happen in the aged, and we said over age 55, but it is not a normal part of the aging process. And women are more affected, and the hands are the most prevalent. So the pathophysiology of osteoarthritis, it will affect the joint as a whole because of biological, chemical, and viscoelastic changes within the joint. Cartilage, synovium, subchondral bone, synovial fluid, ligaments, periarticular muscle, and sensory nerves are altered. Cartilage is a material that is made primarily of water, collagen, proteoglycans, and elastin. This provides joint protection by providing a smooth surface on which bones will glide and disperse loads across the joint. So when the cartilage is damaged, from major trauma or repetitive micro trauma. Again, those repetitive motions, osteophytes are formed by the body to attempt to repair the damage. So the body is going to want to try and fix the problem, but it will not be able to. Osteophytes are projections of new cartilage and bone growth that will form along joint lines, and this will contribute to pain in the joint and then decreased range of motion. Osteophyte formations on the proximal interphalangeal joints and distal phalangeal joints are referred to as Bouchard's nodes and then Heberdine's nodes. So, cartilage loss is a clinical feature of osteoarthritis, causing the bone to be unprotected, which will lead to the deterioration of joint function. Synovium is a membrane that will line the non-cartilaginous surfaces of highly mobile joints, and this will produce synovial fluid, serving to lubricate the joints. However, this synovial membrane may become thickened and overproduce the synovial fluid, and this will cause more pain and even greater restriction on joint movement. So chronic effusions and overproduction of synovial fluid may cause collateral ligaments to stretch, leading to joint laxity or looseness and then mechanical instability, and this is going to compound the joint damage. Ligaments, elastic band type structures that connect bones to bones, may experience edema and then fibrosis. Fibrosis, is the thickening and scarring of connective tissue, and this will contribute to the pain and then the decreased joint function as well. So some clinical manifestations of osteoarthritis are progressive pain over time, decreased range of motion, tenderness to touch over the joint line or around the joint, bony swelling, soft tissue swelling, deformity, instability. And ladies and gentlemen, listen up, and then listen up one more time. Crepitus. Crepitus is a crackling, grating sound or feeling due to air or gas under the skin, and this may also be present. Patients will experience more pain with activity, which will improve with rest. Ladies and gentlemen, please pay attention to this slide. You will want to remember it. So, how is this osteoarthritis? How is it diagnosed? Diagnosis can be made based on clinical manifestations without laboratory testing or radiographs. Radiographs is a fancy name for an x-ray. When the patient is 45 or older and presents with persistent usage-related pain in several joints, and then that morning stiffness that will last for less than 30 minutes. Now, please remember this 30-minute time frame because we are going to talk later on about rheumatoid arthritis, and it will also have that 30-minute time frame. So, but when we're talking about osteoarthritis, less than 30 minutes is going to be the time frame. And then the American College of Rheumatology has developed criteria for diagnosis of the hand, the hip, and the knee. And this was done initially back in 1986, but this criteria is still very current today. So laboratory testing may be performed to rule out other diagnoses such as rheumatoid arthritis, otherwise known as RA, and laboratory testing should also be conducted as part of the medical management to monitor for side effects for medication use. So, radiographs for osteoarthritis. Plain radiographs of the affected joints, such as the hands, the hips, knees, and the spine, along with the history and physical exam, can be used to confirm this diagnosis. Evidence will include joint space narrowing, subchondral sclerosis, and this is the abnormal hardening of body tissue, or cysts, and then the presence of the osteophytes. Plain radiographs, however, may not show evidence until the disease is very well advanced. So early x-rays may not really show much. The treatment of osteoarthritis, ideally both pharmacological and non-pharmacological therapies should be utilized. And then, unfortunately, right now, there is no therapy that is available to stop the progression of osteoarthritis. So, the goal of care would be to include decreasing the pain and then improving or maintaining the joint mobility while avoiding the toxic effects of pharmacological therapy because the medications that we're going to talk about can be quite toxic to the body. So let's talk first about non-pharmacological therapies. Non-pharmacological therapies will include the following. Weight loss, right? That's going to, because weight loss, obesity is the most modifiable factor. So weight loss, if it is indicated, heat and cold compress applications, aerobic exercise. Now, when we're talking about aerobic exercise, I'm not asking you to go out and run a mile. That would be the worst thing that you could do with osteoarthritis. And I'm not asking you to join a Zumba class or, go hard cardio. No, we're not talking about that. We're talking about walking. We are talking about swimming. Physical therapy, including range of motion and then those muscle strengthening exercises, the use of ambulatory assisted devices, walkers, canes, appropriate footwear such as lateral wedged insoles. This may not be the person who should be walking around in a pump, and then occupational therapy. Non pharmacological therapies can also include joint protection, energy conservation, assistive devices for those activities of daily living. And then also important is patient education about self management programs and then social support. So now pharmacological therapy, let's talk about that. Acetaminophen, which is Tylenol, can be used in patients with mild to moderate pain. It is safe to use in doses that does not exceed 4 grams daily. So be sure to ask the patient about history of their liver if there is a liver disease. And then severe pain, or those who are refractory, meaning refractory is another name for unmanageable, meaning that it is very difficult to manage their pain, to acetaminophen. And so now we're going to bump up from acetaminophen to an NSAID, a nonsteroidal anti-inflammatory drug. Now, we need to be careful about this because there can be an adverse effect of GI bleeding, and if they take too much, they can develop an ulcer, an ulceration. So that is also going to contribute to the GI bleeding. So if refractory, and then again, that means resistant to acetaminophen and NSAIDs, then we are going to move on to intra-articular injections of corticosteroids or hyaluronic Excuse me. So it is acceptable and safe to use acetaminophen, NSAIDs, and intra-articular medications in conjunction with each other, meaning that this is something we can mix and match. Patients should not use more than one NSAID because of increased risk of, again, that bleeding, the development of gastric ulcers, there is a risk of renal damage. And then opioid analgesics are an option and should be used sparingly because they may become habit forming. Now, ladies and gentlemen, please listen up. On page 402 in your textbook, and I am using the third edition textbook, table 20.1, medications that are used in the treatment of osteoarthritis. You are going to want to take a look, ladies and gentlemen, at that table. At least one exam question will be coming from that table. And then complications of osteoarthritis is chronic pain, decreased function, toxic effects of medications because of the liver and the kidneys, and it can also negatively affect comorbidity conditions such as diabetes and then heart failure related to decreased ability to exercise. And then surgical management of osteoarthritis. Surgical intervention may be necessary for some patients suffering from disability and then severe pain. Procedures will include arthropic irrigation and or debridement, and this is when the joint is irrigated and then expanded. The surgeon will expand the joint to remove any debris that is in there. And then arthroscopic synovectomy, and this is to remove the excessive growth of that synovial membrane that is causing pain. And doctor can also do a surgical fusion, and this is fusing together the joint surfaces to eliminate any movement of the joint. So now the joint will really be stiff and the patient will not be able to move the joint. It will be the way it is. And then total joint replacement, and that is surgically replacing the joint surface with a prosthesis. So now let's get to this care plan for osteoarthritis: nursing management, assessment, and analysis. So clinical manifestations are related to pain and decreased function of the affected joints. There may be clinical manifestations related to pharmacological therapy. These may be an unsteady gait, bony enlargement or swelling of affected joints. The patient may complain of fatigue. They may talk about painful range of motion of the affected joint. And then when we are doing a lab, we may see something that we call an elevated serum creatinine that will be secondary to an NSAID use. So now, when we're talking about serum creatinine, I know we haven't gotten there yet, but that is an indicator for kidney function. And so if your patient is taking an NSAID, if they are taking an NSAID daily, if they are taking more than one NSAID daily, then that is putting the kidney at risk. So doctor is going to have to monitor this kidney function, and he is going to do it with this serum creatinine level. And then elevated liver enzymes will be related to multiple medication use, because remember, whatever medications the patient is taking is going to be metabolized in the liver. And then constipation could be secondary to decreased physical activity because it's difficult for the patient to move, and or use of narcotic analgesics. So some nursing diagnoses for osteoarthritis: pain related to the disease process, ineffective sleep pattern related to the pain, it is uncomfortable for them to sleep, and then self-care deficit related to a decreased range of motion. So some nursing interventions for osteoarthritis: we always start with assessment, and we are going to always start with vital signs. Hypertension may occur related to chronic NSAID therapy. So one of the side effects, ladies and gentlemen, of taking an NSAID is that your client or your patient may have an elevated blood pressure. Now, there's nothing wrong with them cardio-wise, heart-wise, or anything like that. It is simply a side effect of the NSAID. And this will alter their renal function, of course, because it's going to be filtered by the kidney. And again, we're going to be monitoring, or doctor is going to be monitoring, that serum creatinine level, and then reducing sodium excretion, and then enhancing fluid retention. And then we are going to monitor their weight. The use of an NSAID may lead to weight gain, again, because of the sodium component. And then we're going to be looking at that skin integrity. Always go back to fundamentals, and skin breakdown may occur over bony prominences because of decreased physical mobility. And then, as always, please remember, doctor is going to be monitoring, and we can also be looking at that serum creatinine level as it may be increased. So some nursing actions for osteoarthritis: we are going to administer analgesics and anti-inflammatory medications as ordered. We are going to provide cold packs for those painful joints, and then provide a heating pad for painful muscles. So, ladies and gentlemen, teaching for osteoarthritis, patient education for osteoarthritis. You are going to educate your patient and their families to take medications as prescribed. Misuse or overuse of analgesics and anti-inflammatories may lead to side effects, and that can be somewhat dangerous. NSAID therapy may increase the risk of a myocardial infarction, an MI, GI bleeding, stomach ulcers, renal insufficiency, and then an abnormal platelet function. So although NSAIDs, are very helpful, sometimes they can harm the body. And we are going to educate them to report chest pain, abdominal pain, any abdominal bleeding, and blood in the stool or in the emesis, as this could be a sign of NSAID toxicity or MI. So we will educate the patient or the client to participate in regular physical therapy. assist with referring the patient to occupational and physical therapies, assist with referring the patient to orthopedic surgery when that is necessary, because surgery may be necessary for end-stage osteoarthritis once other treatments have failed. And then we may have to assist with a home healthcare referral. And then how do we know? How do we know that we've done a great job taking care of this patient with osteoarthritis, evaluating those care outcomes? It is important for patients to maintain their function. So a well-managed patient has pain under control and has got good unrestricted movement. Patient compliance with therapy is best achieved when they and their support system are well educated and understand why therapies are prescribed and the possible negative outcomes that are related to non-compliance. So moving on to rheumatoid arthritis now. So the epidemiology of rheumatoid arthritis, the onset of RA, may occur at any age, is most common in the third through the fifth decades, and the incidence increases after the sixth decade. So osteoarthritis, I think the age was 55. And so with rheumatoid arthritis, we are talking about the third through the fifth decades, so 30s through the 50s. The exact etiology is unclear. First-degree relatives of patients with RA are at a 1.5-fold higher risk than the general population. So we call this atopic, meaning that it runs in the family. So if there is a relative or a family member that is positive for RA, chances are you could be too. Environmental factors such as cigarette smoke, bacteria, and viruses have been implicated as initiating factors for development of RA. And then the pathophysiology of rheumatoid arthritis. It is a chronic systemic autoimmune inflammatory disease that is characterized by an inflammatory process that will affect diasthodal, meaning freely moving joints, causing pain and swelling. Involved joints are usually distributed in a symmetrical fashion, meaning bilateral wrists, ankles, or knees. It primarily targets the synovial membrane again, and then the exact pathophysiology is unclear. Unknown antigen triggers an immune response leading to this synovial tissue damage. So now, again, if we are comparing with osteoarthritis, it is only going to be on one side of the body. It's going to be unilateral, whereas with rheumatoid arthritis, it is going to be bilateral, meaning it's going to happen both wrists, both ankles, both knees. So the immune system in rheumatoid arthritis will fail to distinguish self from non-self, and this will cause destruction of the synovium of joints. The synovial membrane becomes thickened again and promotes the destruction of the joint. Less common is the inflammation in other organs, including the lungs, heart, skin, kidneys, blood vessels, salivary glands, bone marrow, and the nervous system, leading to vasculitis, lung fibrosis, neuropathy, and kidney disease. So some clinical manifestations of rheumatoid arthritis will include joint pain, joint swelling, erythema, morning stiffness. Now, the morning stiffness here with rheumatoid arthritis is going to exceed 30 minutes. In osteoarthritis, it is less than 30 minutes. In rheumatoid arthritis, it is more than 30 minutes. And the patient will complain of fatigue. Onset will be insidious. Insidious meaning gradual or subtle, with vague complaints of joint and muscle pain that will evolve into joint pain with synovitis. Synovitis meaning inflammation of the synovial membrane. The synovial membrane is going to be pissed off and angry, and this will lead to joint destruction and deformity. If left untreated or not treated well, this will lead to irreversible joint damage and then disability. So ladies and gentlemen, listen up, and then listen up one more time, please. Common joint deformities will include a swan neck deformity, and this is caused by hyperextension of the proximal interphalangeal joints. Boutonniere's deformity is caused by an abnormal flexion of the proximal interphalangeal joints, and ulnar deviation caused by the lateral deviation of the phalanges. Rheumatoid nodules may be formed in subcutaneous tissue over a bony prominence. And page 406 in your textbook, again, I am using the third edition, table 20.2, there will be a table that will compare osteoarthritis to rheumatoid arthritis. And ladies and gentlemen, you are going to want to know that table. At least one exam question will be coming from that table. So some clinical manifestations of rheumatoid arthritis include extra articular, meaning outside of the joint. And these clinical manifestations will include osteopenia, and this is decreased bone density, muscle weakness, and then episcleritis. And this is painful inflammation of the episclera. And the episclera is a very thin vascular layer of connective tissue between the sclera, which is the white part of the eye, and the conjunctiva, which is the clear outer membrane of the eye. And there will not be a discharge. Scleritis is an inflammation of the sclera, which will produce deep ocular pain. Pleuritis, this is inflammation of the lining surrounding the lungs. Pleural effusions, this is excess fluid accumulation around the lung. Pericarditis is an inflammation of the fibrous lining that surrounds the heart. An enlarged spleen, and then anemia. So you can see here that these clinical manifestations are much more serious, much more complex than with osteoarthritis. So medical management of rheumatoid arthritis, how is this diagnosed? So this is diagnosed by combining clinical manifestations, what the doctor will see, laboratory values. So now there are going to be lab values that are attached to rheumatoid arthritis that are not attached to osteoarthritis. And then radiographs or an ultrasound. And again, the ACR and the European League Against Rheumatism have worked together to update their criteria for diagnosing the disease at an earlier age, because we know that earlier treatment, the earlier that we can get this patient into treatment and start them on their treatment plan, the better they're going to do. So the criteria will assign point values to joint involvement, laboratory values, and then the duration of symptoms. So laboratory testing for rheumatoid arthritis is not conclusive, but it will be done to help with diagnosis and to monitor for, again, those side effects that are related to medication use. So the presence of antibodies, rheumatoid factor, and anticyclic citrulline peptides may assist in the confirmation of the diagnosis. So a positive rheumatoid factor does not always indicate the presence of RA. Other autoimmune diseases may have a positive rheumatoid factor as well. Acute phase reactants, such as a C-reactive protein, CRP, and erythrocyte sedimentation rate, the ESR, may be used to detect inflammation, but it is not specific for RA. It just means that there is an inflammatory process going on in the body somewhere. An elevated CRP and/or ESR is an indicator that can be helpful in distinguishing inflammatory from non-inflammatory arthritis. So what this means, ladies and gentlemen, is that if my patient has an elevated CRP and an elevated ESR, it is a very good indicator that they probably have rheumatoid arthritis as opposed to inflammatory arthritis. So obtaining information regarding renal and then hepatic, meaning the liver, is necessary before initiating therapy, as many medications that are used to treat RA can be toxic to the kidneys and then the liver. So a baseline complete blood count are necessary because anti-rheumatic medications can cause what we call cytopenia. Cytopenia is reduced amount of blood cells. So an elevated platelet count may indicate the presence of inflammation. Before the initiation of most biological therapies, and we'll talk about that in a little bit, an option for treatment of RA, a tuberculin skin test, and hepatitis testing should also be performed, as some of these biological therapies have the potential to reactivate a dormant infection. Radiographs. Radiographs for rheumatoid arthritis. Conventional radiographs are used to assess for bone erosions and joint space narrowing. These may be repeated during treatment to assess for disease progression and the efficacy of pharmacological therapy. So we can see if things are getting better or worse. MRI can detect erosions not detected by conventional radiographs, and ultrasonography may be used to assess for synovitis and erosions that are not detectable by plain radiographs. Good option for patients who will decline an MRI. So treatment of rheumatoid arthritis, non-pharmacological therapy. Education, of course, is very important in the management of RA. Patients must understand their disease and the measures they can take to help manage the disease process. Range of motion exercises will promote joint mobility, reduce stiffness, and then improve muscle strength. And again, aerobic exercise will promote good cardiac health. Non-pharmacological therapies, physical and occupational therapies may be necessary to teach patients appropriate exercises, teach patients how to protect their joints, evaluate the need for assistive devices, and then teach the proper use of that device. Proper nutrition is important to maintain good health, prevent obesity, and then decrease the risk of heart disease. And it is important for patients to take rest periods to manage fatigue and then their joint pain. So, pharmacological therapy for rheumatoid arthritis. The goal of pharmacological treatment is to control the inflammation that will lead to joint and tissue destruction, decreasing joint pain, synovitis, and stiffness, as well as maintaining joint function and then preventing joint destruction. Treatment decisions are based on disease severity and then the patient's response to the medications. Initial treatments will include analgesics, the NSAIDs, and then glucocorticoids, So analgesics, including acetaminophen and narcotic agents, will provide only pain relief with no alteration in the disease process, meaning that we are going to manage the pain, but we are not going to halt the disease. Anti-inflammatory medications will provide pain relief and some reduction in inflammation. However, again, these will not alter the disease process. Glucocorticoids such as prednisone may be given orally, intramuscularly, intraarticularly, or IV, and they can suppress inflammation and alter the disease process. However, they are not safe at high doses over a long period of time. Patients with RA whose disease does not respond very well to a combination of analgesics, anti-inflammatory agents, and low-dose prednisone are treated with what we call disease-modifying anti-rheumatic drugs, and we call these DMARDs. Synthetic DMARDs will include methotrexate, Arava, Plaquenil, azolfidine, and Xeljanz. Each will alter the immune system in various ways, altering the inflammatory process to decrease inflammation. Now, these medications, these DMARDs, they will slow the disease progression. These medications may be used alone or as monotherapy or in conjunction with one another. So again, doctor can mix and match. Before starting DMARD medications, patients should inform their healthcare provider of a history of or exposure to active tuberculosis. Many patients will respond well to methotrexate. It is accepted as a first-line DMARD of choice, so that is going to be the first-line medication. Methotrexate is taken once a week orally, subcutaneously, or intramuscularly. Now, ladies and gentlemen, please listen up. On page 407, there is a safety alert regarding methotrexate. You are going to know that safety alert because there will be at least one exam question coming from that safety alert. Traditionally, patients will move on to additional or alternative medications if methotrexate alone does not control the disease. So over the last decade, several medications known as biologics. Now, biologics are genetically engineered medications made from living organisms and their products, such as a protein. So these biologics have obtained approval by the U.S. Food and Drug Administration to treat RA. These medications have proven to be beneficial in slowing or even halting, again, the disease progression. To date, the approved biological therapies must be infused by IV or injected subcutaneously. So these biologics will target specific entities of the inflammatory cascade, interrupting the immune response and then decreasing the inflammation. Surgical management of rheumatoid arthritis. Surgical interventions include joint replacement or fusion that may be necessary to help alleviate pain. They may not improve function. Patients may choose to have surgical removal of rheumatoid nodules. However, they need to know that these nodules may return over time. Some complications from rheumatoid arthritis. Many complications may be associated with RA. They may be caused by uncontrolled disease or the result of pharmacological therapy. Patients can develop decreased function of joints and permanent joint deformities, which may lead to permanent disability if the disease is well controlled. Is not well controlled. Not well controlled. Extra-articular complications will include increased risk of infection and increased risk of developing cancer. So now the care plan for rheumatoid arthritis. We are going to start with assessment and analysis. So clinical manifestations of RA are related to pain and decreased function of the affected joints. Additionally, there may be clinical manifestations related to pharmacological therapy. So the nurse may also identify an unsteady gait, bony enlargement or swelling of the affected joint, warmth and redness of the joint, painful range of motion of the affected joint. Some nursing management, we may notice increased incidence of infections. And again, because of the NSAID use, doctor will need to monitor that serum creatinine, just like in osteoarthritis. We are also going to monitor those liver enzymes secondary to methotrexate use. Constipation may be secondary to decreased physical activity and or the use of narcotic analgesics. Nausea and oral ulcers may be related to methotrexate use. Cough and or shortness of breath due to interstitial lung disease caused by RA or methotrexate therapy. There may be a self-care deficit, and your patient may complain of fatigue. So some nursing diagnoses of rheumatoid arthritis: pain related to the disease process, ineffective sleep patterns related to the pain, and then self-care deficit related to a decreased range of motion. So some nursing interventions for rheumatoid arthritis. We are going to start with assessment. So we're going to assess the joint pain and the mobility. Joint pain and mobility are indicators of treatment efficacy and disease progression. We're going to assess temperature. An increase in temperature is an indicator of infection. We're going to monitor laboratory testing, that's CRP and the ESR. These lab studies are going to be elevated when there is inflammation present. We're going to look at the hemoglobin. A decreased value can indicate a GI bleed caused by the NSAID use. Remember that GI bleeding. Serum albumin. This can be correlated with severity, and then the platelet count. This may be elevated, actually, in very active disease due to the inflammatory process. So some nursing interventions, we are going to monitor liver and renal function. Elevated levels may be due to medications used to treat RA. We will assess for pleural effusion, pericarditis, pleuritis, scleritis, episcleritis, and osteopenia. These may be present due to the inflammatory changes outside of the joints. So some nursing actions for rheumatoid arthritis. Ladies and gentlemen, please listen up, and listen up one more time. You are going to want to pay attention to this slide. Administer analgesics and anti-inflammatories as ordered. Administer those glucocorticoids as ordered. This is a tapered dose treatment plan. This means that the patient needs to take the medication at the same time every day. The dosage of the medication will decrease, yes, because it is tapered dose. But the important part is that the patient take the medication at the same time every day. Administer DMARD therapy as ordered, and then administer those biologics as ordered. And then teaching for rheumatoid arthritis, ladies and gentlemen, please continue to listen up. We are going to educate on the importance of adherence to the treatment plan. It is essential to maintain the treatment plan to control the disease progression. Report signs and symptoms of infection. Patients must be aware of signs and symptoms of infection and the importance of reporting these to the healthcare provider. Ladies and gentlemen, please take note. Immunosuppressive therapy should be discontinued, should be stopped, while the patient has an active infection. Patients are at a higher risk for developing infections and complications from infections. We will assist with referral to an infectious disease specialist for patients with chronic or atypical infections because patients, again, are at an increased risk of developing these infections. Keep current on vaccinations. Patients, however, ladies and gentlemen, should not receive live vaccines if they are on immunosuppressive therapy. And we can refer to physical and occupational therapies as needed. And then how do I know? How do I know that I've done a great job taking care of this patient with rheumatoid arthritis? Important assessments of the efficacy of pharmacological therapy are the amount of joint tenderness, and the amount of joint tenderness and synovitis the patient is experiencing and the duration of the morning stiffness. Again, it is that 30-minute window. Teaching the importance of using anti-rheumatic medications properly and consistently is key in treating RA patients. Patients should understand that full efficacy cannot be achieved if the medication is not used consistently. Medications can be dangerous if they are used more than they are directed. The patient with well-controlled RA will have very few or no tender or swollen joints with minimal morning stiffness while experiencing little or no adverse effects from pharmacological therapy. So, ladies and gentlemen, we are moving on to lupus. So, the epidemiology of lupus patients are diagnosed between the ages of 16 and 55. Many factors will play a role in the disease outcome. Less educated patients and those with low socioeconomic status are likely to have poor disease control. People who have relatives with SLE are at a higher risk than the general population for developing the disease. Again, this is a topic, it travels in families. So the pathophysiology of lupus, systemic lupus erythematosus, is a chronic inflammatory disease that can affect any organ system. The exact etiology is unknown. Triggering factors will include pregnancy, exposure to sunlight, illness, major surgery, silica dust, and some medication allergies. So some clinical manifestations of lupus, clinical manifestations of SLE are diverse. They do not follow a clinical pattern, and they will vary greatly from one person to another. The clinical course of SLE usually involves periods of remission and acute disease flares. So how is lupus diagnosed? Diagnosis may be complicated and frustrating for many, many patients. There is no specific test to diagnose SLE. Laboratory findings are used to support or confirm the diagnosis when combined with patient history and physical examination findings. The ACR developed a guideline to help with the diagnosis. The Systemic Lupus International Collaborating Clinics revised and validated the classification criteria to aid in the diagnosis. So they identified 17 broad criteria that will align with the clinical manifestations with specific definitions. Some are clinical, some are immunologic. So the clinical criteria will include skin rashes such as the lupus mallar rash, which is over the bridge of the nose and into the cheeks, oral ulcers, thinning hair, joint tenderness, and then pleural or pericardial effusions. Renal disorders, neurological disorders such as seizures or some confusion, hematological disorders, thrombocytopenia, leukopenia, anemia. The immunological criteria includes positive anti-nuclear antibodies, otherwise known as an ANA, as well as other specific antibodies. So now, this is the thing. 4 of the 17 criteria must be present in order to support a diagnosis of SLE. And 1 must be clinical and 1 must be immunological. So laboratory testing is used to confirm some of the clinical and immunological criteria. Testing is done to confirm the presence of antibodies. Patients with SLE will produce anti-nuclear antibody, the ANA. This will confirm the existence of an autoimmune disease. Anti-phospholipid antibodies should also be assessed because the presence of these antibodies may lead to the formation of blood clots. Laboratory values to evaluate the clinical criteria include a complete blood count, the CBC, to check for leukopenia. Leukopenia is a decreased white blood cell count. Thrombocytopenia, that is a decreased platelet count. And then anemia, which is a decreased red blood cell count. Urinalysis with random protein and creatinine and BUN should be evaluated and monitored closely to detect kidney disease early. C-reactive protein and ESR are markers used to identify inflammation. However, these are not specific for SLE. So just as when we were talking about rheumatoid arthritis, these lab studies, the C-reactive protein, the CRP, and then the ESR, these are just going to tell me that there is an inflammatory process going on with my patient. C-reactive protein and ESR may also be monitored to assess for the level of disease activity and then the response to treatment. Radiographical imaging is beneficial to detect or assess some of the clinical criteria or to eliminate other causes of symptoms. So ladies and gentlemen, listen up, and then listen up one more time. Interventions include avoiding prolonged sun exposure and then using a sunscreen and SPF or 50 or higher every day. Every day. This is non-negotiable. A well-balanced diet is recommended for proper nutrition. Frequent rest periods and a regular sleep schedule will help fatigue. Regular exercise will improve strength and maintain range of motion as well as a healthy diet. So pharmacological therapy for lupus, interventions are based on disease manifestations. Anti-malarial medications such as hydrochloroquine, which is Plaquenil, are frequently used. Non-steroidal anti-inflammatory medications such as ibuprofen are useful in treating the arthralgias, myalgias, headaches, and fever. Ladies and gentlemen, on page 390, please listen up right now. On page 390, there is a safety alert with a methotrexate safety warning. Please pay attention to that warning. Glucocorticoids may be necessary to suppress inflammation in joints, kidneys, and other organ systems. Immunosuppressive agents, such as methotrexate, may be necessary to treat joint inflammation, which does not respond to an NSAID or a steroid. Glucocorticoids and immunosuppressive agents may be used in combination with hydrochloroquine to treat more serious clinical manifestations. And then something called Benlysta. This is a biological response modifier. It is the first new approved treatment in 40 years for lupus. Surgical management for lupus interventions may include a renal transplant for patients with severe lupus nephritis and joint replacement for patients at risk for avascular necrosis of the large joints. So some complications of lupus: renal failure, kidneys are not working; premature heart disease, the heart is not working well; interstitial lung disease, the lungs are not working well; hypercoagulation, putting the patient at risk for a stroke; avascular necrosis of the joint is wearing away and becoming ischemic, dead tissue; increased risk for infection; and then toxicities related to the pharmacological therapy. So, nursing management of lupus, the assessment, this is the nursing care plan. The nurse may identify fatigue, difficulty concentrating, joint pain, the rash, again, the malar rash over the bridge of the nose and into the cheeks, photosensitivity, oral or nasal ulcers, dry eyes, dry mouth, hypertension, leukopenia, thrombocytopenia, alopecia. Alopecia is thinning and then loss of hair. And then chest pain. Some nursing diagnoses for lupus: fatigue related to chronic inflammation and altered immunity; altered skin integrity related to the rash; altered self-image related to manifestations such as the rash, and then alopecia. So some nursing interventions for lupus. We are going to assess, and we're going to start with vital signs. Hypertension may occur as a renal or cardiac complication. Fever may be present due to infection, and decreased oxygenation saturation may be present due to interstitial lung disease. So we are going to obtain a past health history. We're going to do a head-to-toe physical assessment. Diagnosis is based on the presence of the 4 of the 17 clinical manifestations in the patient's history and physical assessment, such as the butterfly rash, oral or nasal ulcers, alopecia, musculoskeletal complaints, the joint swelling, weight loss, and blood abnormalities. So what are we going to do? Nursing interventions for lupus. We are going to monitor lab values, the BUN and creatinine, for that kidney function, urinalysis, CBC, CRP, and ESR to identify that inflammatory process, and then coagulation studies. Elevated BUN and creatinine and proteinuria may indicate decreased renal failure, and that is one of the clinical criteria. Decreased white blood cells, platelets, and red blood cells are common and may require intervention. Elevated CRP and/or ESR will indicate inflammation and may require intervention. Coagulopathies are a complication. So some nursing actions for lupus. We are going to administer analgesics and anti-inflammatory medications as ordered. Most patients will require analgesics and anti-inflammatory medications to manage the pain caused by the inflammation. Administer medications as ordered to treat specific clinical manifestations. Managing those clinical manifestations is imperative to the treatment of patients to help prevent any complications. And then teaching for lupus, the patient education. We are going to educate on the disease process. It is very important for patients to understand the disease process, to manage the disease, and to help prevent complications. The patient needs to understand to use sunscreen daily. Again, this is non-negotiable. We are going to educate on energy conservation and activity prioritization. Fatigue is a common complaint, and it can be better managed by ensuring frequent rest periods and activity prioritization. And then we want to keep up to date on immunizations. However, again, this population needs to avoid live vaccines. Patients at risk for infection should not receive a live vaccine if they are on immunosuppressive therapy. Avoiding oral contraceptives in patients with SLE who have migraine headaches, Raynaud's phenomenon, a history of phlebitis, or anti-phospholipid antibodies. These patients have increased risk of hypercoagulopathy, which may be heightened by using these oral contraceptives. Assist in referrals to a pulmonologist, nephrologist, neurologist, cardiologist, and then dermatologist as needed. Complicated clinical manifestations require the care of specialists to provide optimal care. And then how do I know? How do I know that I've done a good job taking care of this patient with lupus? Systemic lupus erythematosus is a complicated disease that can be very difficult to manage. Medication compliance will play a major role in controlling the disease. Frequent evaluations should be performed on a regular basis by a rheumatologist who monitors disease progression and then will treat new clinical manifestations as they arise. Patients with well-controlled SLE are high functioning who can carry out the usual activities of daily living. And then moving on to gout. The epidemiology for gout. Risk factors for developing gout include obesity, hypertension, eating large amounts of meat and seafood, using thiazide diuretics, and then consuming large quantities of alcohol. When metabolized, purine-rich foods such as seafood, meat, and alcohol, this will increase the uric acid production. Thiazide diuretics, such as hydrochlorothiazide, will increase the net rate reabsorption in the renal tubules, and this will increase the serum uric acid level. So gout, pathophysiology of gout. Gout is a disease in which monosodium urate crystals are deposited in joints, bone, and soft tissues, accompanied by inflammation. Hyperuricemia. Hyperuricemia is an elevated uric acid level in the blood, and this must be present prior to the evolution of gout. So this happens because of their nutritional status, eating a lot of red meat and seafood. Hyperuricemia will result from the overproduction of or diminished renal excretion of uric acid. Urate crystals are the result of an oversaturation of uric acid in the blood. So the uric acid will settle out of solution into soft tissue and joints. The body's attempt to rid itself of the crystal deposits results in an inflammatory process, which will cause swelling, warmth, and then intense pain in the affected joint. So these gout attacks resolve after several days or weeks, even if left untreated. Gout can become a chronic inflammatory destructive arthritis. There are 3 phases of gout: acute, intercritical, and then chronic. Acute gout will involve one joint and is characterized by acute onset of pain, redness, and swelling. Intercritical gout is the asymptomatic period between gout attacks. So, if I have an attack in February, an acute attack in February, that is my acute phase. And then once this phase resolves, if I don't have another attack until July, the time between February and July is my intercritical gout phase. If left untreated, the attacks may come more often with a shortened intercritical period. Chronic tophaceous, gout is characterized by repeated attacks of many years, leading to the production of tophi. Tophi is uric acid deposits or nodules in the joint, and this is joint destruction. Podagra is the term used to identify gout in the first metatarsal. The severity of the attack usually peaks 12 to 24 hours after onset. So the medical diagnosis of gout, how is this diagnosed? A presumptive diagnosis may be achieved by combining objective, subjective, and laboratory data. The definitive diagnosis can be made only by observing crystals in synovial fluid or tophaceous material. Joint erosions and soft tissue nodules are radiographically consistent with chronic gouty arthritis. The presentation of septic arthritis and pseudo-gout may mimic an acute gout and may not be differentiated by clinical examination alone. In some cases, it is necessary to examine joint fluid for uric acid crystals to make that definitive diagnosis. So ladies and gentlemen, please listen up, and then listen up one more time. You're going to remember this slide. Treatment of gout, non-pharmacological therapy. Non-pharmacological treatment will consist of weight management because obesity is a modifiable risk factor. Alcoholic beverages, ladies and gentlemen, such as beer, should be avoided because they will increase uric acid production. Splinting of the affected joint may also be useful in protecting the joint and alleviating pain. Pharmacological treatment of gout will depend on which stage the patient is in when they request treatment, when they seek treatment. Acute gout management is focused on pain relief and then the reduction of the inflammation. Common medications will include NSAIDs such as indomethacin, otherwise known as Indocin, and colchicine, which will decrease the buildup of uric acid crystals in the joint. Glucocorticoids are used to reduce inflammation and then provide pain relief. So ladies and gentlemen, listen up, and then listen up one more time. Pharmacological therapy of gout, management of intercritical gout will consist of the use of NSAIDs and colchicine. Managing chronic gout will focus on the use of uric acid lowering agents. Now, uric acid lowering agents such as allopurinol, or Xyloprim, or Uloric will inhibit the production of uric acid. One very important fact to remember, ladies and gentlemen, is that acute gout is never treated with a uric acid lowering agent such as allopurinol. For unknown reasons, a rapid change in the serum uric acid levels is going to provoke or worsen the gout attack. And then complications of gout, urate crystals can aggravate to form a stone, making gout patients more likely to experience a kidney stone. So the nursing management of gout, this care plan, the assessment and the analysis, clinical manifestations are related to pain and decreased function due to the accumulation of urate crystals and tophi in the affected joint. The nurse may identify intense joint pain, tenderness on palpation of the affected joint, swelling of affected joint, redness of the affected joint, warmth over the affected joint. There may be decreased range of motion, and there may be the presence of tophi. So some nursing diagnoses for gout, pain related to the disease process, and then knowledge deficit related to the disease process and the treatment. So some nursing interventions for gout. We are going to assess. We're going to monitor that uric acid level. Hyperuricemia will promote crystal formation. We will assess for the presence of tophi. Tophi are those lumps or hard nodules under the skin around the joint. The presence of tophi is indicative of advanced gout. We will assess for red, swollen, and painful joints. Red, swollen, and painful joints will indicate an acute gout flare. We will assess pain levels. Evaluating pain will help determine the occurrence of the flare and the efficacy of treatment. Some nursing actions for gout. We are going to administer those uric acid lowering agents as directed, administer analgesics and anti-inflammatory medications as ordered, and administer glucocorticoid therapy as directed. Ladies and gentlemen, please listen up, and then listen up one more time. Teaching for gout, patient education. The patient needs to know that they need to avoid alcoholic beverages, especially beer. They need to take their uric acid lowering agents as directed. They need to know to report gout flares promptly, and they need to be educated on proper nutrition. And then how do I know that I've done a great job taking care of this patient with gout? The goal of treating gout is to eliminate the gout flare and prevent joint destruction. So a well-managed patient will take gout-lowering agents appropriately. They will avoid foods containing purines, such as seafood and red meat, and they will limit their alcohol consumption, especially beer. And fibromyalgia. We are going to end with fibromyalgia. The epidemiology of fibromyalgia is the most common cause of chronic musculoskeletal pain in female individuals between the ages of 20 and 55. Fibromyalgia is commonly found in patients with rheumatic conditions such as RA and SLE. The onset of fibromyalgia usually occurs in middle adulthood. It may occur in adolescence or later in life. Genetic factors may play a role in predisposing patients to the development of FM. So the pathophysiology and then the clinical manifestations of fibromyalgia. Fibromyalgia is a chronic pain disorder of soft connective tissues that is characterized by widespread pain and other symptoms such as insomnia, fatigue, stiffness, and cognitive dysfunction. For example, the inability to focus on something or to concentrate on a task. The etiology and pathophysiology of this disorder are unclear. Current theories include the abnormal processing of stimuli by the central nervous system, which will cause normal pain signals to be amplified. So the amplification of stimuli causes FM patients to feel pain, whereas someone without FM would not feel any pain. Fibromyalgia may be triggered by an infection or physical or emotional trauma. In females, the menstrual cycle can affect sensitivity to pain. Normal daily stress combined with common FM symptoms can create a cycle that will build one on another. So, the medical management, the diagnosis of fibromyalgia. Laboratory testing is not necessary to diagnose FM, and should be limited to those tests that are necessary to rule out other diagnoses. History and physical assessment are used to diagnose FM. Patients often report hurting all over or feeling as if they have the flu. Other complaints include fatigue, headaches, cognitive impairments, and abdominal pain. Physical examination of the patient is essentially within the normal range with no evidence of joint or muscle inflammation. In 2010, ACR preliminary diagnostic criteria for FM does not require a tender point examination and provided a scale for measurement of the severity of symptoms that are characteristic of FM. These criteria were based on patient self-reporting, making a complete history a critical part of the examination. According to the 2010 criteria, a patient satisfies FM criteria if the following three conditions were met: widespread pain with an index greater than 7, symptoms that have been present for at least 3 months, and there is no other disorder that would explain the patient's symptoms. Ladies and gentlemen, please listen up, and listen up one more time. Treatment of fibromyalgia, non-pharmacological therapy. Non-pharmacological therapy includes physical therapy, strength training, aerobic exercise, cognitive behavioral therapy, education, and then self-management. Cognitive behavioral therapy may be used to help understand the illness and then to help change the patient's behavioral response to pain. So, pharmacological therapy for fibromyalgia. Pharmacological therapy includes medications that will alter chemicals in the brain, such as serotonin and norepinephrine, or that will block overactivity, of the nerve cells. Other medications may prove useful, or those that will improve sleep and treat pain. So, the nursing care plan, nursing management, assessment, and analysis. The nurse may identify the following clinical manifestations of FM due to enhanced pain perception and stress related to the enhanced pain: fatigue, arthralgia. Arthralgia is joint stiffness, and then myalgia is muscle aches and soreness. Headache, abdominal pain, the decreased desire to participate in activities, non-restorative sleep, and then anxiety. So, some nursing diagnoses for fibromyalgia: chronic pain related to the disease process, ineffective coping skills related to chronic pain, depressed mood related to the chronic pain, ineffective sleep patterns related to chronic pain. So, some nursing interventions for fibromyalgia. We are going to assess, and we're going to start with vital signs. Pain may alter vital signs. There may be an increased heart rate or an increased blood pressure. We're going to assess affect. Depression may be an associated symptom because of chronic pain. And then assessing pain. Fibromyalgia causes chronic pain. Increased levels indicate ineffective treatment strategies, whereas decreased pain levels indicate effective treatment and self-management. So, some nursing actions for fibromyalgia: administer medications as ordered, non-steroidal anti-inflammatories, antidepressants, anti-seizure medications. Pain management is an integral part of managing patients with FM. Non-steroidal anti-inflammatories will manage inflammation. Antidepressants will manage the depression, promote sleep, and help control pain through inhibition of the reuptake of neurotransmitters while inhibiting pain transmission to the brain. Anti-seizure medications work for unknown reasons. We will provide a heating pad for painful muscles and cold packs for painful joints. Please remember, heat is used to relax the muscle, increasing blood flow to the affected area. Cold packs may soothe an aching joint. And then teaching for fibromyalgia, patient education. We will educate the patient to take the medications only as prescribed. Improper use of medications can be very harmful. Proper use of medication is required in order to receive the desired effect. We will encourage the patient to participate in regular physical activity. We will educate them on effective coping skills. We can assist with referring the patient for a sleep study. Ineffective sleep may increase pain and fatigue. We can assist with referring the patient to a mental health provider if that is necessary, and assist with referral to occupational and physical therapies as needed. And then, how do I know that I've done a good job taking care of this patient with fibromyalgia? Compliance with a healthy diet and exercise regimen and getting adequate rest are essential in essential in managing FM. Taking medications as prescribed will help to control the enhanced sensation of pain and the depression that is associated with the disease process. And a well managed patient has decreased pain and fatigue, healthy sleep patterns, and maintenance or improvement of strength and function. And ladies and gentlemen, that is all for connective tissue disorders. I thank you for your time and attention. And if you have any questions, any thoughts, any issues, please reach out.